Hello and welcome to the Arrhythmia Interpretation in Intermedicine Clinical Skills. The topics that will be covered here include supraventricular arrhythmias. We'll be looking at narrow complex tachycardias which are regular and irregular, ventricular arrhythmias, wide complex tachycardias which are regular and irregular, as well as pacemaker rhythm. Let's get started. So this waveform of an ECG actually explains to us the exact location at where depolarization and repolarization takes place. So as you can see at the beginning of the waveform, we have the sinoatrial node, and this is where the electrical signal begins. Then the electrical signal moves and contracts the atria, both right and left side, and that is essentially the P wave. Subsequently, there will be an overlap during atrial contraction where the electrical impulse actually moves towards the AV node or the atrioventricular node, and then it moves on to the bundle of His, the bundle branches, and it reaches the Purkinje network. That makes the PR interval. As soon as the electrical signal reaches the ventricles or the V, it then produces depolarization of the ventricles, causing the QRS complex. The QRS complex also reflects the repolarization of the right and left atria. And finally, a V, as you can see, which is the T wave, represents the repolarization of the right and left ventricles. Let's now begin with the arrhythmias. So here we have supraventricular arrhythmias, and I'd like to emphasize the two different common types of supraventricular arrhythmias, which are atrial ectopics as well as sinus arrhythmias. So here it just refers to arrhythmias that begin above the ventricle, and the common ones would be the atrial ectopics, as you can see, also known as premature atrial complexes, which are premature beats arising from ectopic pacemaking tissue within the atria. There is an abnormal P wave followed by a normal QRS complex. Then we have sinus arrhythmia, which is a sinus rhythm with a beat-to-beat variation in PP interval, which is the time between successive P waves, producing an irregular ventricular rate. Next is narrow complex tachycardia. Here, it is divided into sinus tachycardia, AV re-entry tachycardia or AVRT, AV nodal re-entry tachycardia or AVNRT, and atrial flutter. Let's first take a look at sinus tachycardia. So sinus tachycardia is usually secondary to a possibly reversible condition. Its inappropriate sinus tachycardia is a primary condition diagnosed in patients with persistent symptomatic sinus tachycardia in which the causes have been excluded. There are common two causes, which are pharmacological and non-pharmacological causes. Pharmacological causes include beta-agonists, sympathomimetics, antimuscarinics, and others such as caffeine and theophylline. And non-pharmacological causes such as exercise, pain, anxiety, hypovolemia, hypoxia or hypercarbia, sepsis, anemia, and pulmonary embolism can also cause sinus tachycardia. Next, let's take a look at supraventricular tachycardias, in specific AVRT and AVNRT. So AVRT stands for atrioventricular re-entry tachycardia, and AVNRT stands for AV nodal re-entry tachycardia. AVRT. So in antidromic AVRT, anterograde conduction occurs via the accessory pathway with retrograde conduction via the AV node. It's much less common than the orthodromic AVRT. The rate is usually 200 to 300 beats per minute, and the wide QRS complexes due to abnormal ventricular depolarization in accessory pathway. As for AVNRT, it is the commonest cause of palpitations in patients with structurally normal hearts. It's typically paroxysmal and may occur spontaneously or upon provocation with exertion, caffeine, alcohol, beta-agonists, or sympathomimetics. It is more common in women than men and may occur in young and healthy patients as well as those suffering chronic heart diseases. Now let's complete the narrow complex tachycardia, which is the regular form, by explaining atrial flutter. It is a form of narrow complex tachycardia with a regular atrial activity at least 300 beats per minute or more. You may also see a sawtooth appearance of inverted flutter waves in lead 2, 3 and AVF. The pathophysiology of flutter is actually caused by a re-entry circuit within the right atrium. The length of the re-entry circuit corresponds to the size of the right atrium, resulting in fairly predictable atrial rate, which is around 300 beats per minute. Next, narrow complex tachycardia, which are irregular, and these are atrial fibrillation, atrial flutter, which is variable, and multifocal atrial tachycardia. Atrial fibrillation is an irregular rhythm with no P waves, absence of an isoelectric baseline, and there would be variable ventricular rate. Take note of the fibrillatory waves that may be present and can be either fine, which is amplitude of less than 0.5 millimeters, or it could even be coarse waves where it has an amplitude of more than 0.5 millimeters. Sometimes these fibrillatory waves may mimic P waves, hence leading to misdiagnosis. Next, we have atrial flutter with variable block. So typically atrial flutter is a regular narrow complex tachycardia, but if there's presence of variable degree of atrioventricular blocks, then it becomes an irregular waveform. So you can see the diagnosis of flutter with variable block could be inferred here from the RR intervals alone, where the RR intervals during periods of 4 to 1 block are approximately double the RR intervals during 2 to 1 blocks. Next is multifocal atrial tachycardia. It is a rapid, irregular atrial rhythm arising from multiple ectopic foci within the atria, most commonly seen in patients with COPD or congestive heart failure. It is typically a transitional rhythm between frequent premature atrial complexes and atrial flutter or fibrillation. The heart rate is usually more than 100 beats per minute. It is irregular rhythm with varying PP, PR and RR intervals. At least 3 distinct P wave morphologies in the same leads are seen. This kind of waveform is usually seen in those with respiratory diseases such as COPD or a chronic lung disease, or even presence of cor pulmonale. Next would be ventricular arrhythmias, and here specifically we would like to highlight ventricular ectopics, or also known as premature ventricular complexes or PVC. It is sinus rhythm with PVCs of 2 different morphologies as shown in this arrow. Note the appropriately discordant ST segments and T waves. So typically the ectopics are broad QRS complexes, which is more than 120 milliseconds with abnormal morphology. It could be premature, which means it occurs earlier than would be expected for the next sinus impulse. Discordant ST segment and T wave changes are seen, usually followed by a full compensatory pause, and retrograde capture of the atria may or may not occur. Now, let's move on to the wide complex tachycardia, again, which can be divided into regular and irregular. For the regular part, we are just going to focus on the monomorphic ventricular tachycardia. Monomorphic ventricular tachycardia, or VT, is a broad complex tachycardia originating from the ventricles, hence the QRS complex being broad. There are several different varieties of ventricular tachycardia, but the most common one is monomorphic ventricular tachycardia. The heart rate is usually typically more than 100 beats per minute, and you also happen to notice there's absence of typical right bundle branch block or left bundle branch block morphology. Next is the wide complex tachycardia, which are irregular. And what we'll be covering here include polymorphic ventricular tachycardia or torsade de pointes, ventricular fibrillation or VF, and atrial fibrillation with WPW syndrome. So this is how a polymorphic ventricular tachycardia looks like. It is a form of ventricular tachycardia in which there are multiple ventricular foci with the resultant QRS complex varying in amplitude, axis, and duration. The most common cause of polymorphic ventricular tachycardia is myocardial ischemia or infarction. Tosa de Pointes or TDP is a specific form of polymorphic ventricular tachycardia occurring in the context of QT prolongation. It has a characteristic morphology in which the QRS complexes twist around the isoelectric line. Next would be ventricular fibrillation or VF. It's the most important shockable cardiac arrest rhythm. It is invariably fatal unless advanced life support is rapidly instituted. It is chaotic with irregular deflections of varying amplitudes. There is no identifiable P waves, QRS complexes, or T waves. The rate is typically between 150 to 500 beats per minute, and the amplitude decreases with duration. Could be from coarse VF to fine VF. So this is a fatal condition because the ventricles are not able to contract well, producing adequate cardiac output. And finally, under the topic of wide complex tachycardia which are irregular, we have atrial fibrillation with WPW syndrome. And here you can see that there is intermittent pre-excitation. Some of the impulses are transmitted via the AP or the pre-excited beats, producing characteristic delta waves typically seen in V3, and other impulses are transmitted via the AV node, producing narrow QRS complexes. So there is characteristics of atrial fibrillation seen where fibrillatory waveforms of over the isoelectric line with no P wave and they are irregular in nature, as well as the presence of WPW syndrome, where it's characterized by the presence of delta waves. Now, before we end our session today, let's take a quick look at a pacemaker rhythm so that we can familiarize with this type of rhythm and identify the presence of a pacemaker based on an ECG. So the appearance of an ECG in a paced patient is dependent on the pacing mode used, obviously, where the placement of the pacing leads, device pacing thresholds, and the presence of native electrical activity. Features of a paced ECG include pacing spikes, as you can see in this ECG. They are vertical spikes of short duration, usually 2 milliseconds, may be difficult to see in all the leads. The amplitude depends on position and type of lead. Bipolar leads result in a much smaller pacing spike than unipolar leads, and epicardially placed leads result in smaller pacing spikes than endocardially placed leads. Well, we have come to the end of this session of an introduction to arrhythmia interpretation. We hope it was insightful and thank you for your time.